Okay. Happy day, everyone. This is Shwetha Murali from Psychology program of M.O.P College. So today we'll be looking at the topic clinical picture of schizophrenia. You would have heard of what schizophrenia is, probably from fictional stories or probably from books that you've read, right? Schizophrenia basically is a mental disorder, or it's a psychological disorder characterized by perceptual oddities in thinking, in action, the way we feel, and the manner of speech, as well as the manner of relating to other people, right? So you would have seen fictional characters also portraying schizophrenia. Some examples are the movies Beautiful Mind. The Russell Crowe portrays someone who's suffering from schizophrenia, and there's also Shutter Island. Apart from that, you would have seen Adam West in Family Guy, whose delusions has brought the downfall of too many scenarios in society. Okay, so apart from that, there is a very obvious a candidate, that is Alice in Wonderland. The hallmark of schizophrenia is psychosis. That is, there's utter loss of touch of reality. Okay, and which is marked by symptoms like delusions and hallucinations. Schizophrenia, as a word, it comes from the Greek word split, schizin and phren. Schizin means splitting off, and phren means mind. Okay, so we shouldn't confuse this as splitting of personality or splitting of identities. That is seen in dissociative identity disorder, which was earlier known as multiple personality disorder. So here in schizophrenia, it is the splitting of our thoughts, the split between thoughts and emotions, and the split between our thought and external reality. The National Mental Health Survey in India in 2016, the prevalence of schizophrenia was about 0.8%, which is a very significant number. And usually this disorder affects males much more than females. Usually males have an earlier onset and they have a severe clinical picture of schizophrenia. Even the brain imaging study shows that the anomalies of the brain of a male schizophrenia patient is much more worse than that of a female. So there's a sex ratio imbalance when it comes to schizophrenia. Usually, if we see male to female ratio in schizophrenia, it's about 3:1. Okay, and the main reason behind this is the protective factor of estrogen in females. Yeah, usually when estrogen levels decline, as seen in premenstrual levels or as seen in menopause, usually that's when the clinical picture gets worse. Otherwise, the delayed onset and the better prognosis is explained by the protective factor of estrogen. So these are the symptoms overall. This is the overall symptoms of schizophrenia. We have both positive as well as negative symptoms. We are going to look at each one by one. The first one is delusions. Delusions are erroneous beliefs. They are false beliefs that the person with schizophrenia seems to hold in spite of clear-cut contradictory evidence. They seem to hold some beliefs very firmly, even though other people in their own society, in their own culture, religion, say no, this is not true. Yeah? Okay? So this is a disturbance in the content of thought. Delusions occurs in almost 90% of schizophrenia cases. It is very, very prominent. And usually the most common delusions are as follows. First one is made feelings or impulses. In made feelings or impulses, usually the patient suffering with schizophrenia believes that their thoughts, their inner feelings and impulses is controlled by another person or another external party. And in thought broadcasting, they feel that their innermost speeches, their private speech, their private thoughts is broadcasted to all other external sources, even against their will. And thought insertion is the belief that somebody else is inserting new thoughts in their head, right? And finally, there's also thought withdrawal, which is the feeling or which is the belief that the patient has that other people are robbing them of their own thoughts. Okay, this is closely related with made feelings or impulses, where they think that other people are controlling their thoughts, emotions, and their private speech. Yeah, and also there's delusions of reference. Delusions of reference is where a neutral environmental situation, which has no personal meanings whatsoever to the patient, seems to be seems to be making an impact on the patient. That is, let's take an example. I have observed this when I was doing my internship. The patient with schizophrenia was watching this TV show. It was Sun Music, and out of the blue, they told suddenly that the song, it is for me. Okay, the song's reference is made up for me. It has a personal meaning attached just for me. Okay, they're playing this song just for me, and the RJ or VJ, whoever is speaking, I know him personally. He is plotting something against me, or this song was made out just for me. Okay, you would think that this is pretty irrational, and no way was it personally meaningful to them, but then they take that personal meaning, right? And also there's delusions of bodily changes. Sometimes patient believes that their bowels are not working, or sometimes the organs are missing altogether, that their extremities are missing and so on. So these are the delusions, which is the first positive symptom of schizophrenia. Moving on, the second one is hallucinations. Hallucinations comes from the Greek or Latin word halluciner, which means to wander in mind. So here, hallucinations are refers to false perceptions of objects. So it is a false sensory experience that the person believes is taking place in front of their eyes, even when there is absence of any external stimulus. Okay, so this is different. Clearly, this is different from illusion, where it is a misperception of an existing stimulus. There is some stimulus which is actually there, but then there is a misperception. That is illusion. Okay, let me clear this difference with an example. So in illusion, there is actually a bush, and you are misperceiving it to be a man who is crouching. Okay, that is illusion. So there is an external stimulus, there is sensory distorting that is taking place, and you're perceiving that bush to be a man, right? But in hallucination, there is no bush at all to begin with. There is no external stimulus out there, but you still see a man there. Okay, there's no one there, there's no bush, there's no object, but you see a man there. Then that is a clear-cut example of a visual hallucinations. If you take hallucinations, the most common type of hallucination is auditory hallucinations. It occurs in almost 80% of the cases of schizophrenia. Hallucinations can occur of any sensory modality, with auditory being the most common one and the tactile being the least one. Okay, so here, even in healthy individuals, we sometimes tend to hear hallucinations even when our phone is actually not ringing. We feel like it's ringing and we can hear it ringing. These are common ones. And when actually a healthy individual is under a lot of stress, and when they have taken too much caffeine, they also seem to experience a bit of hallucinations. All these have been proven in research studies. Yeah, and when you take people with schizophrenia, they seem to attach these hallucinations. They seem to incorporate their hallucinations into their delusions, as though confirming the delusion, and they also seem to be too emotionally involved. Usually, the voices that they hear in these delusions are very critical ones or very hostile ones, which takes the upper hand. It's a dominating voices that they hear. And obviously, the most susceptible patients are one with low self-esteem. They usually succumb to these voices, and they act as whatever in whatever ways the dominating voice tells them to do also. Yeah, because they are emotionally tangled in it, right? And there was a study done by Naini and David who interviewed and who observed about 100 patients suffering with schizophrenia and who had auditory hallucinations. Patients with schizophrenia who had auditory hallucinations, the voices that they were hearing was of normal conversational volume. It wasn't like a voice shouting or a very feeble voice. It was a normal conversational volume, and it was more than one voice in a lot of cases. They were hearing multiple voices in their head, and also the voices also seemed to mimic somebody they knew, somebody who was familiar, okay, a significant other or a friend or relative that they knew, right? And in some cases, the voices was of a total stranger, was that of a god or evil spirit commanding them to do something. And one thing, like I already told, in most of these cases, the voices were hypercritical and were hostile towards this patient, saying, there's no one who loves you, you are an orphan, you're out there in the streets all alone. They were very critical and they were very harsh voices like these. But in a very minority of cases, there was also supportive voices saying, you can do it, I'll help you through this. There were voices which did that also. And one common phenomenon in hallucinations is that the auditory hallucinations and the visual hallucinations, they seem to take place when the patient was alone. Not only like taking place, the auditory hallucinations were the worst, right? And with the worst in severity and in terms of multiple voices only when the patient was alone. Yes, and coming to the next part, there were a lot of neuroimaging studies done. Neuroimaging studies are nothing but PET and fMRI scans. And here, in these studies, it was proved that patients with speech hallucinations have reductions in gray matter, brain volume, in left hemisphere auditory and speech perception areas. Not only that, you would expect an increase of activities like Wernicke's area, which is for speech comprehension. But on the contrary, here, in people who are experiencing speech and auditory hallucinations, they were reporting an increased activity in Broca's area, which is responsible for speech production. Yes, and comparing with healthy volunteers, there were also another study done where healthy volunteers who didn't have schizophrenia, they were asked to imagine that they were hearing other people talking to them. Okay, even in this, there was a brain activation which was similar to that seen in patients with schizophrenia experiencing auditory hallucinations. Yeah. And finally, there is TMS. TMS is transcranial magnetic stimulation. Transcranial magnetic stimulation is a procedure where you pass magnetic waves through the skull to reduce activity in the underlying areas. When this was done in the speech production areas and all, there was a reduction of hallucinations seen. Okay, so this could possibly be a mode of treatment also, trying to reduce the auditory hallucinations. And finally, there was a conclusion reached by a number of studies, especially with Gold's landmark study, that patients misinterpreted their own self-generated and verbally mediated thoughts as coming from another external source. So these voices in their head actually is nothing but their own self-generated inner speech or private speech. And this self-generated inner speech is known as subvocal speech. This was actually proven in Gold's study. He did studies on a lot of patients with schizophrenia as well as healthy controls who didn't suffer from the disorder. I will first explain a little bit what subvocal speech is. Subvocal speech, like I told, it's inner private speech. It's that mental dialogue which we don't want it to be heard. It's just for our own mind. You know that dialogue, right? Mind voice and நினச்சி சத்தமா பேசிட்டு இருக்காங்க. That is subvocal speech. Okay, so here just take an example. Your mom asks you to take out the trash for like 5-6 times in the morning, and in the evening also your grandfather is again reminding you like 10 more times like to take out the trash. In the late evening or the night, without you even like consciously being aware of it, you just mutter out, have to take out the trash. Okay, this is a very almost negligible decibel, but it's your self-generated speech which is getting broadcast to other people, right? This is subvocal speech, and this is what seems to be happening in patients with schizophrenia, right? So Gold first did brain imaging studies where he took this procedure called as electromyography, which is EMG, to study the muscle activity of both the schizophrenia patients as well as the healthy controls. And when he noticed that when the patients with schizophrenia were experiencing auditory hallucinations, there was an elevated level of muscle activity of the vocal cords. Okay, so when the patients were imagining those voices in their head, or like when they were experiencing auditory hallucinations, it was clearly noticed that there was increased production, there was increased vocal muscle activity as well. So the speech is generated by the person only, by the patient suffering with schizophrenia. But then how come it is almost inaudible, like you can barely hear it, and how come the person isn't recognizing it's their own voice? First of all, when the next thing Gold did was he tried to amplify the speech. He tried to use a microphone and he put it against one of the patients experiencing auditory hallucinations very close to their throat. And actually, he could hear those inner thoughts. Those so-called auditory hallucinations were played out. He could hear the thoughts. And he tried to match the content. He asked, tell me what did those voices in your head tell you? It was the same, exact same content as the content of the voice, of the amplified sounds heard through the microphone. Okay, and when the patient reported that they were hearing auditory hallucinations, at the same time the vocal muscle cord activity was also going on, right? So this basically tells us that these auditory hallucinations are just misperception. It is our own subvocal speech, right? That is recorded at a very, very feeble level. And not only that, how come these, next question, one rational question would be, how come they're not able to recognize it's their own voice? If these mental dialogues are getting played out, how come they're not able to recognize it's their own voice, right? So the answer to this is that whenever we hear whenever we hear our own sound, we have an unconscious recognition neural circuit that gets activated, right? Which matches the sound that we hear with the predicted sound of our own voice. But this matching doesn't happen in the case of people suffering with schizophrenia. Moving on, the third positive symptom, we have seen two positive symptoms so far, delusions and hallucinations. The third positive symptom is disorganized speech. Here, whatever the people with schizophrenia, suffering with schizophrenia say, it seems to be communicative and it seems to have a proper syntax and proper grammar. But then you won't be able to understand or comprehend an iota of what they're saying. It's all incomprehensive speech, otherwise known as word salad. When they're speaking some sentence or something, it seems to be okay grammar-wise, but then comprehension-wise is nothing there. You won't be able to understand what they're saying. It's just a mixed jumbling of random sentence and phrases, and sometimes you have neologisms. Neologisms is basically a new made-up word. Okay, for example, I can say, please bring that glass of detone here. Okay, the word detone doesn't exist. Okay, yes, ketone exists, it is a proper chemical. The detone, it seems as though makes sense, but then it is actually a made up word. Okay, so people with schizophrenia use a lot of these neologisms. Not only neologisms, another symptom that is seen in disorganized speech and behavior is echolalia. Echolalia is repetition of one's own words again and again, or repetition of other people's words or phrases in a repetitive manner. Yeah, and this as a whole is called, also referred to as formal thought disorder. Next is disorganized behavior. People with schizophrenia, they have a total disruption in all goal-directed behavior, be it social, occupational, or other important areas of functioning. They can't, it is to the point where you don't recognize them anymore. And they have a lot of unusual and silly behavior as well. For example, when it's a really hot day, they will be wearing number of layers, like a lot of jackets on. And when you ask them, are you comfortable? They say, yes, I'm comfortable. Okay, they don't show any discomfort as well. And also, there's very, very low levels of, low standards of normal day-to-day hygiene that they maintain. Grooming behaviors are also sometimes non-existent in severe cases. A prominent symptom that is seen in disorganized behavior is catatonia, where there's almost no movement of the limbs, and when the person is mute for some time, doesn't talk, doesn't move, just stays like that for extended periods. Or another form, this is called as catatonic stupor. Another form is also where they just lay in an outstretched position with limbs just one of the limbs just shaking, or in a very uncomfortable position for a very long time. And again, they do it seemingly without any discomfort, right? And also, all these impairment, this disorganized behavior could mainly be because of impairment or dysfunctioning in prefrontal regions of the brain, especially the prefrontal cortex, which is your executive functioning center. So these are common catatonic behaviors. And finally, we have negative symptoms. First, we have been talking about positive and negative symptoms for a long time. What are these positive and negative symptoms? right? So positive symptoms mean that there is a distortion of normal repertoire of behaviors and skills that is to be seen in a healthy individual. There is excess of something. There is excess and distortion of normal behaviors and experiences, like your delusions and hallucinations, right? And negative symptoms, on the other hand, is absence of normal behavior and experience. So here you have two categories in negative symptoms. First is reduced expressive behavior, where they don't show any sort of facial expressions, where they have a flat and blunt effect. Whatever you ask them, there isn't much going on in their facial expression, or they will answer only in monosyllables or not even that. Okay, they are the least responsive to anything that you say or try to communicate to them. Allogia, where there is reduction in speech altogether, where they are rendered mute. And the second category is reductions in motivations or in the experience of pleasure. Here we have avolition and anhedonia. Avolition is lack of goal-directed behavior, right? Here they might just stare into blank space, into one wall for long hours put together. And in anhedonia, they seem to lack taking pleasure in activities that they previously used to take pleasure in. So there's no motivation or pleasure-seeking tendencies whatsoever in the picture of schizophrenia. Yeah, and study shows that yes, people with schizophrenia may appear emotionally unresponsive, but that doesn't mean that they're not going through the emotions. Okay, on the contrary, these studies have showed that they are experiencing plenty of emotions. It's just that they don't show it, right? There's also physiological arousal movements that is recorded to prove that they are going through a lot of emotions. But when it comes to that expression part, that's where they are lacking. Yes, and finally, if a patient has negative symptoms, that indicates poor prognosis. Finally, this is the criteria. This is the DSM-5 criteria for schizophrenia. I'm not going to go too much into this. So basically, for the symptoms that we just saw, all the 5 positive and negative symptoms that we just saw, you need at least 2 of these to exist at least for a period of 1 month. And as a whole, the duration of this disorder for a person to meet the criteria, duration criteria, is about 6 months. And there is clinically significant disturbance in social, occupational, and other important areas of functioning. And also, this disorder, the symptom seen in the disorder is not better explained by another disorder like schizoaffective or bipolar with psychotic features. And also, the symptoms of this disorder is not explained or is not attributable to a substance or a medical condition. So that is about it. These are the reference. I've also attached a case study for your reference. You can go through that. And goal study is also attached. You can read that. It's a very interesting study. You can read it more in detail. So that's about it. Thank you so much.